Hi, I'm Roger O'Toole from the Melbourne Headache Centre, and welcome to this talk on post-concussion syndrome with Associate Professor Alan Pearce. Alan is a neurophysiologist and also Director of Neuro Sports Labs here in Melbourne. He's an adjunct associate professor at La Trobe University and is author on over 200 peer-reviewed papers and is considered an international expert in concussion. In this discussion, Alan will help us understand some of the differences between concussion, post-concussion symptoms, and CTE, or chronic traumatic encephalopathy, which is the long-term neurodegenerative changes associated with repeated trauma or bumps to the head. We'll also hear about what Alan does as a neurophysiologist in terms of measuring brain function. Now, as we know, concussion is the invisible injury, so there's very little to see, if anything, on neuroimaging. However, Alan uses two techniques to actually measure how well the brain is functioning. At the end of this discussion, we introduce a collaboration that Melbourne Headache Centre is forming with Neuro Sports Labs. Through Neuro Sports Labs, you'll get the best possible understanding of how your brain is functioning. And at the Melbourne Headache Centre, we're going to treat the underlying sensitivity that is being driven by the neck. And during this talk, you'll understand how important that is in trying to manage post-concussion symptoms. I hope you enjoy the talk. I'm joined today by Associate Professor Alan Pearce.
G'day.
From Neuro Sports Labs, and that's actually where we find ourselves today. And we're here to talk about concussion.
Yes.
It's very topical at the minute. Lots of controversy in the concussion space, but I think it's fair to say it's an evolving space anyway, just from without the controversy.
Yes.
But from a scientific point of view, in terms of what is sort of happening.
Yeah.
So it might be best to start with just tell us about concussion.
Well, I guess it's a multifaceted injury that has not only just neurological effects, but psychological effects, sociological effects, cultural with attitudes towards the injury. So it's this whole sphere now around concussion, which is essentially a brain injury. And I think that's the important takeaway message here, is that it's not just a knock to the head, like they talk about colloquially, but it's a subset of a mild traumatic brain injury.
Right. And what are the, in terms of the science, I guess, what do we see in terms of the brain injury? What does that look like?
Well, I guess, we call it a constellation of signs and symptoms. We see the obvious ones where we think concussion is a loss of consciousness or being knocked out, but that only occurs in about 10% of concussion injuries. But we see a range of other things, so nausea, confusion, dizziness, aggression, irritability, headache, absolutely, even anxiety, depression can be associated after the injury. So even though some people may not necessarily think of it as classic depression, but you do see people who come off or have been concussed crying and quite flat after. So and people can have different ways of reacting to it as well, and we only need one of those symptoms following an observable impact that may or may not necessarily be directly to the head.
So it may just be a change in mood.
Yeah, that's right. Absolutely, yes. And so we only need one of those with a known impact to diagnose it as a concussion injury.
And certainly in the headache space, some of the literature I've read in terms of the temporal relationship from the concussion or the impact to actually symptoms coming on can be quite a long time. So it's not necessarily what you are noticing instantaneously or in the first few days, but there can be
That's right. So it is what we call an evolving injury. So as you said, you can get an observed impact. Nothing may occur, but for some people it might be minutes, others it might be hours, and in some cases it could be a day or two after that the symptoms start to come on.
And that echoes, and we're going to talk to in a moment, the symptomatic overlap between migraine, but also something like whiplash and persistent whiplash, where yes, there's obviously an event that leads to that, but the actual symptoms can evolve over weeks sometimes.
That's right. I'm looking forward to you educating me on on whiplash.
I'll do my best. So that there's a lot of talk at the moment in terms of persistent post-concussion symptoms, but also this thing called CTE. So, and often the two seem to get mixed together. So maybe if you could explain what the differences there are and what that means.
Yeah, absolutely. So obviously there is a time period for people to recover after a concussion. Now that time period varies between individuals, but it could be anywhere from 7 to 30 days. And we are now, the science is now telling us that it's probably going to be closer to that 30 days rather than 7. But when we talk about people with persistent post-concussion symptoms, or other people call it post-concussion syndrome, we're talking about people who have ongoing symptoms for maybe 3 months or longer.
And again, that could be any one of those symptoms.
That's right.
Yeah.
Generally, it tends to be headache, and I guess nausea, and probably also depression. But headache is certainly the one of the key indicators, and fatigue as well.
Right.
And so it sort of seems to not go away or dissipate, and people are concerned that it might be a psychological issue. But what we're seeing with persistent post-concussion symptoms is that, in my research, is that it seems to be an ongoing physiological. So it may be continued inflammation with some of the supporting cells that help, as I said, supporting cells that help the brain cells or neurons functioning. But we're still trying to work that out.
Well, I was going to say, this is where we're sort of headed with the talk. But
that's right. But certainly, people are not sure why their symptoms are continuing on. So, given a lot of the discussion in the wider community and the media around what we call CTE, which is chronic traumatic encephalopathy, or encephalopathy, depending on where you come from, tomato. They're two different things. And so CTE really is a long-term neurodegenerative disease. It's not persistent post-concussion symptoms. And
you don't even necessarily need to have a concussive event.
That's right.
For that.
So CTE is part of the umbrella of dementias.
Right.
And so one of the defining features of CTE, as opposed to Alzheimer's or frontotemporal dementia or Lewy body, is the fact that people who have experienced repetitive trauma, so as you said, a lot of knocks to the head, and sport is probably the obvious area where CTE is, I guess, greatest risk. In the football codes, because of the repetitive knocks or repetitive impacts from tackling, bumping, elbows, going to ground in training, but and also in matches. And so when we talk about a lot of the retired footballers, with cognitive impairments, mood disorders, movement disorders as well, that's when we're talking about CTE, not necessarily that really intense ongoing problems that are more around persistent post-concussion symptoms.
And this relates to the research that was just published
from the Australian Sports Brain Bank, the first 21 brains, where we found 14 of the 21 had CTE. But all had played or had participated in repetitive sport.
But not all elite sport, was it?
Not all. No, that's right. So a couple of things from that was not all from elite sport. So a number of them were under in sort of sub-elite or club players.
So community level, but
community. That's right. Absolutely. A number of them. Well, the difference in the group that had CTE versus the people who didn't have CTE was a huge difference in age. So it was seen in younger people, and also the fact that we saw a number of suicides as well. So that was a concern. So it is a degenerative disease, not necessarily tied in with ongoing symptoms after a concussive event.
Right.
Yeah.
So if we circle back to the persistent post-concussion symptoms, and I think this is where I initially met you and actually became aware of your work, was I think you were presenting in Sydney at a conference up there.
Yeah.
And to be honest, being a headache clinician and dealing mainly with migraine and related conditions, I was sort of wondering why I was listening to a talk on concussion, because I'm not in the sports world. But then I think there was a slide you put up which was just sort of listing the symptoms of persistent post-concussion, and it was headache, nausea, dizziness, brain fog, sleep, and then it made sense. Why am I here? Well, because that looks exactly like a migraine. You know, all of the same symptomatic profile.
Yeah.
And again, if you then overlay ongoing whiplash in association with that, and so this is where I guess we started to bump heads. Say, well, you know, we know that, or it's likely at least, that when you've had a concussion, that the neck has also experienced significant.
Oh, absolutely. I mean, if you
trauma.
look at any concussive event, whether it's in a car accident or on the field or even falling downstairs, it's not just an isolated impact to the head, obviously the brain, but the neck is moving, as well,
and absorbing a lot of that mechanical force.
Yeah, absolutely.
And so this is where I guess I became quite interested in we see these symptoms change in our migraineurs who often have no history of trauma leading to these symptoms. So the question, I guess, arises as to how much of the ongoing symptoms are related to tissue damage, even at a microscopic level, and potentially ongoing inflammation, but how much may be coming from potentially a neck sensitization impacting on these brain stem structures that we see with migraine.
Absolutely.
And it's been quite interesting in the media the last week, where these seem to have come out as well with I think Cade Kolajasny just yesterday or the day before saying that his symptoms were put down to a neck injury.
That's right.
And again, it almost seems quite ridiculous, but again, when you look at the spread and the overlap between these different things, it can, it's quite murky. It's quite difficult to sort of sift through.
Yes, exactly. So, we need to, obviously look at, I think, as a holistic injury, not just one or the other. And part of it, I think, has been misrepresented because of the CTE issue. Yeah. Because CTE is obviously a form of dementia, we've only focused on the brain. Yes. And so we have kind of forgotten about, or not forgotten, but probably, kind of brushed over, subcortical areas of the brain and the neck and even the spine as well.
Well, I think once a significant injury is excluded, so we do an MRI or something to look at the structures and can see there's no ligament damage, there's no bony damage. Yes. Move on. That's the focus then shifts very much back to that's the thing. It's known as the invisible injury. Right. And that's one of the things too that we tend to obviously then diagnose a concussion rather than a moderate or severe traumatic brain injury, because an neuro image, MRI, CT is negative. Yep. And that then complicates things further, because if you can't see it on a scan, what do you work off? Exactly. And we need to look at it from a different perspective. Yeah. Yeah. Well, and that's where we're hoping to sort of collaborate. So
absolutely.
Talk to a little bit about how you assess what you can actually see from a functional point of view. Yeah, well, I'm a neurophysiologist by training, and so I try and look at the excitability and the inhibition pathways of the brain. And the technique I use to look at that is a technique known as transcranial magnetic stimulation. When we talk about TMS, it is, and that's why we say TMS. Yes. But the reason why, when we talk about TMS, most people assume TMS as being the therapeutic device to help treat with depression. And it is that technique, but there are two forms. There's the therapeutic version, which is what they use in repetitive TMS. So they do trains of pulses, right? Which works. Is that the same as what they trialing in migraine as well?
Yes, that's right. Yep. Yes. So it's probably a lighter form of ECT treatment. Right. So with repetitive TMS, you can go in, you get your 20 minutes of stimulation. You can get out of the chair, and you walk, and you can drive home. Whereas with ECT, obviously, it's you're sedated, you lose the day, and it's very invasive. TMS, repetitive TMS is not for everyone though. So it's still a work in progress, and that's why they're trying to look at it from other perspective. But at present, it's only for Medicare. It's for depression only.
Right. Yep.
But there is another form of TMS, which is what I use for research and diagnostics, and that is known as single pulse TMS. So when you stimulate the brain, you can actually get what we call an evoked potential, which is a waveform. And that waveform gives us the physiology of the excitatory pathways, but also the inhibitory pathways.
Okay.
And we can read that quite simply with an electromyography.
So essentially just getting a measure of how easily the brain is conducting signals.
Exactly. So our brains work on a balance between excitation and inhibition. Whether it's one neuron talking to another neuron, or a couple of neurons, or it's one region of the brain talking to other regions of the brain, it's still very much balanced around excitation and inhibition. And that helps control the balance of our neural impulses.
And relating that back to the headache and migraine watchers, we see this is what sort of changes in the lead up to an attack, and so there's neuroimaging looking at these pathways that normally inhibit pain signals all of a sudden stop inhibiting, and this burst of activity comes through. So
exactly, and that's what we're hoping to see. Well, we can see it with TMS as well.
Interesting.
And so there's different ways that we can measure the waveform. We can use EMG, which is just some electrodes over a target muscle, or we can also use it with EEG as well. So we can get different parts of the brain looking at their excitability and inhibition following a pulse. So unlike EEG, which just measures the activity of the brain, we're actually evoking the stimulus.
Right.
So we're actually stimulating the neurons and seeing how they behave.
So rather than looking at spontaneous activity, you're testing.
We're testing it. And the whole idea is that healthy brain cells or healthy neurons will respond a particular way. If there's any impairment, whether it's through concussion or migraine or headache or anything else, they won't respond in the same way. And so we can compare.
Great. And so what we're hoping to then look at is potentially a group of people that are going to be assessed and look at this excitability and then see whether we can actually, when we're treating them and seeing their symptomatic profile change, do we also see a change in
so it gives us that mechanistic mechanistic reason or data on the effectiveness and efficacy of your techniques.
Starts to figure out why it does what
it
does.
That's right. Yes, exactly. So it's more than just understanding symptoms. It's trying to understand why the symptoms increase or hopefully decrease after a treatment.
Indeed. And the cortical.
So the other part of what I do here is I look at the neurosensory or somatosensory pathways. So with TMS, I'm sort of looking top down. With the cortical metrics, I'm actually looking at ascending or bottom up. And so the whole idea around this technique, which has got about 50 years of science behind it, is that similar to TMS, neurons will behave a particular way. So if you look at sensory neurons, they will send signals to the brain which need to be perceived in a particular way. Again, healthy neurons will be sending healthy signals to be perceived in a particular way. But if we have some impairment in the brain, then they're not going to be able to detect certain stimuli as effectively. So again, we run through a range of different battery of tests that will be picked up by different parts of the brain, and again we compare people who've had a history of concussions or some sort of impairments versus healthy people who've never had any impairments.
And so this looks at things like reaction time and
that's right. So reaction time in being able to
discrimination.
That's right. Yes, lateral inhibition, things like that. Yeah, absolutely.
There was at the conference that you presented at last year, there was a really interesting, all your work's interesting, but there's a particular paper where people had returned to activity and passing their cognitive tests and seemingly okay, but working harder for the same
That's
for
right.
the same output, and you could actually see that with this testing.
Yes, that's right. So, with the, I guess, the overall program of research I do in the chronic space. So, part of it is to try and see if we can detect CTE in living people. That's the goal. But at this stage, it's just trying to detect what we call pathophysiology in ex-footballers and ex-athletes who've had a lot of repetitive hits to the head. And one of the things that was sort of coming through more from an observational perspective was that when they did their cognitive testing, so whether it's reaction time, memory testing, concentration testing, just by classic neuropsych methods, they were completing the tests as well as the controls. So, at the end of the test, you would see the amount of errors or the amount of correct answers, and they weren't really...
So they were back to baseline, essentially.
Yeah, they were showing that they were quite healthy, if you could say that. But one thing that was happening was that it was taking them much, much longer. And so what I wanted to do was to dig into that data. So unlike reaction time is where you just get a stimulus and you just respond. A lot of the other tests are what we call response times, because that takes processing in the brain to detect the signal, what does it mean, and then provide a answer that is either correct or incorrect. And when you add those layers of variables on top of the response, then the people who were showing a history of repetitive injury just took longer to get the right answer.
So they're still performing well on the test.
That's right.
But
and
different
that's,
level of performance.
That's it, absolutely. And that's where a lot of them would come to me and say, I'm told that there's nothing wrong with me, but I'm taking much longer, or I just work so much harder to get to that point, and no one's, and I'm just wondering, is it just me, or is it is it something that's not real? And so what we've been able to find is that they're actually taking longer to get the correct response, which I think is really important, because it means that we've got to give these people due credit that they've actually got something wrong, whereas they get told there's nothing wrong with them, or worse, they get told they're malingering, which is devastating for them psychologically.
Would be so familiar to people watching.
That's right.
As you say, it's invisible.
Exactly.
And, how do you explain? I just don't think as well as I used to.
Absolutely. So, and then on top of that, when they finish their test, they're absolutely buggered because they've had to work a lot harder.
So, actual exhaustion.
Absolutely. So, the way I try and explain it is that the engine of the car is really not running as optimally, and unlike a car, you can't go and get a tune-up, but it's a car that is still getting you from A to B, but it's using more petrol, it's taking longer, and it's probably overheating as well.
It's a great analogy.
So
I'm going to steal it.
More than welcome to. But that's the thing. So I'm trying to argue, particularly to psychologists and that we also need to quantify their response time as much as we quantify their actual performance.
So that's about it here from Neuro Sports Labs. Absolutely fascinating talk. So thank you very much for your time, Alan.
You're very welcome.
And hopefully we see some interesting things come out of the collaboration. So again, we're looking to see people that are having persistent post-concussion symptoms. So beyond sort of 3 months, and somewhere probably before a year. So in that sort of range, that are looking to have an assessment with yourself with the techniques that you've described today, but then go through a treatment program with us at Melbourne Headache Centre, and then we'll do a reassessment and actually see what's changing and what's not. Terrific.
Great.
Thanks for your time.
You're welcome.
Well, I hope you enjoyed that discussion with Alan. It was wonderful that he could give up his time to share some of his experience with us. So if concussion is impacting on your life, what do you do about it? As Alan explained, in the majority of cases, concussions will resolve within 30 days. But what do you do if your symptoms are persisting beyond that? This is now what we call post-concussion syndrome. Step 1 is to contact Alan at Neuro Sports Labs. This will give you the best understanding of how your brain is functioning after the concussion. At the same time, contact us here at Melbourne Headache Centre to book an assessment, but book that assessment for after you have seen Alan. What this does is gives us a baseline of information about your brain function before we treat you. During your assessment here at the Melbourne Headache Centre, we'll be able to determine whether or not there are things about your presentation that we can change with the techniques we use. If we can clearly help you, then we will treat you for 2 sessions a week over 2 weeks as an initial treatment block. We expect significant change within this time. We then move very rapidly to a self-management program, and typically a total treatment block lasts around 6 weeks, with an average of between 7 and 8 treatment sessions. The final step is then to book a reassessment with Alan. This is important because it will help you to understand how well your brain is functioning now that the symptoms have changed, and whether or not there are further things that you need to do to restore your health. So take the next step in your recovery today. Contact Alan at Neuro Sports Labs via info@neurosportslabs.com. You can also give us a call here at Melbourne Headache Centre on 03 8648 6487 or go online and fill out the online assessment form. Make sure you indicate when you book with us at Melbourne Headache Centre what your booking date is with Alan for an assessment. Hope to see you soon.